Today we get to welcome our very own Dr. Gina Rempel here at our February Breakfast at SSCY seminar series on this warm Tuesday morning in February. Today we're going to be hearing about the art and the science of supported mealtime management for children with neurodevelopmental challenges. But before I pass this over to Dr. Rempel, I would like to begin that we are acknowledging that we are located on Treaty 1 territory, the ancestral lands and traditional territories of the Anishinaabe and Aniniwak, Athinawak, Dene Sudan, Anishinaabe, Inuit, Dakota, and Nakota peoples, and the homeland of the Métis Nation. We also acknowledge that our water is sourced from Shoal Lake 40 First Nations. And at Rehabilitation Center for Children, we are committed to equity, diversity, and inclusion. So to introduce Dr. Rempel, Gina is a neurodevelopmental pediatrician who has spent a lifetime watching children eat. Locally known here as the feeding doctor, she is a clinician, teacher, and active participant in research and knowledge translation activities on a national and international committees that advocate for children with disabilities in general and focus on nutrition support in particular. Administratively, she holds leadership roles at the Provincial Nutrition Support Programs and has a 30-year affiliation with the Rehabilitation Center for Children. She frequently speaks at conferences and here at seminar series, sharing her experiences to widen the table so more children will participate in the life-affirming activity of eating. So thank you so much for joining us today, Dr. Rempel, and I will now turn this seminar series over to you. Thank you so much.
Thanks very much, Liz, and thank you for inviting me to have a virtual breakfast with you. Somebody was just saying to me yesterday how we missed the actual breakfast series that we haven't had the pleasure of participating in for a long time now. But thanks for inviting me virtually to your table. And let's talk about widening the table for children with neurodevelopmental impairment. I call the talk Beyond Aspirational Thinking because too often when we are mealtime planning for kids, often with complex needs, we stop when we're faced with aspiration. Aspiration is our worry point. It's our tipping point. It's where we worry about whether or not safety and participation can meet or separate. But our thinking process that aspiration is a limiting factor limits that participation for children. And I know that's a bit of a shift in the way we think, but let's talk about it some more. We think much more about participation when we are looking at our favorite words, and this has become a key concept in disability care for children. And it's thanks to the genius of these people. This slide is borrowed from a friend of mine who we presented a talk on favorite words together. And she had the genius of putting the Einstein hair on the three of these people who are really at the center point of our favorite words and our shift in thinking from a focus on fix it to a focus on participation. And our favorite words have really done that through the work of Andrea Cross, Peter Rosenbaum, and Jan Willem Gotha. We focus on participation even when the tasks are difficult and when they aren't pretty. And these favorite words can shape our planning. And I want to tell you how we can do that even in the face of aspiration. We need to think about can do, not fix it. We don't want the aspiration to be automatically limiting. So how do we move beyond aspiration, and how does the art and science of supportive mealtime management impact our approach? That's what we're going to focus on today. I can tell you that I don't have any commercial relationships to disclose, although like in this piece of art, and you will be seeing a number of pieces of art through this art and science talk, I do like lots of species at the table, which you can see here depicted in this piece. And I've had the privilege of feeding many species over my years of traveling to Australia, where my son was a vet, and my daughter still lives. So there are many little creatures that I have had the pleasure of participating in mealtime with, and it really has been a joy to do so. But we want to talk about little humans, and we want to talk about widening the table. And certainly we all know that mealtime is how we celebrate, how we relate, how we communicate, how we socialize, and how we as little humans learn about our heritage and culture. And mealtime can't be separated from all of these human activities and why it's so important to most of us. And I would venture to say that it is the most important developmental task that we have to master. Most of us don't view it as a medicalized activity, but eating together is what is a life-enriching activity. And the same is true for parents of children who have eating and drinking difficulties. They too value eating as a life-enriching activity. And more, they are choosing to eat or feed their children in the face of risk. And of course, this decision places children, families, healthcare providers at odds, because we as health professionals are trying to address health and well-being and safety, but the parents are interested in that shared sensory experience and that sense of normalcy. So that places us as professionals in the bullseye, in the center, because we are at the crossroads of those decisions. And sometimes community agencies and schools and others look to us to be the mediators in that debate. So our learning objectives for today are to identify those points of controversy in the literature regarding approaches to mealtime management, to recognize the multifaceted strategies that mitigate risk and optimize participation, and to appreciate that delicate balance between risk and participation. And we're going to do that by looking at some cases, like this little guy. This is Adam. These pictures are all taken from the internet, so they are the faces are not hidden for that reason. We all know Adam or somebody like him. He's 5 years old, he has CP, and he's about to enter school. He needs assistance in all areas of daily living, GMFCS5, which is a term that most of us understand to be the child who has the most significant motor impairment. He loves to eat, and his parents really enjoy feeding him. It's not pretty, it's not very well coordinated, and clinically there are signs of aspiration, and that's been raised by his therapy team. But he's never been hospitalized, he's never had a chest infection, he's well nourished, so his parents are at odds with the school team that say they won't feed him orally. And the parents are quite distressed. You're in feeding clinic, they're saying, help us out here. And the school members are in the clinic room as well saying, help us out here. And we're at that crossroads of trying to understand, what does this mean? He's never been hospitalized. He has clinical signs of aspiration. Is it safe to feed him at school? Well, so let's look at what the science tells us, because when we have people in the room who are trying to engage with us and trying to understand the situation, we need to look to science to help explain to us what we should be doing. We know that children with eating and drinking difficulties are definitely at risk for both malnutrition and dehydration. And they often present in a clinic setting with prolonged and stressful mealtimes. And even if you asked Adam's parents to describe a mealtime, they would probably tell you that he has been struggling for a while, that he has prolonged meal times, that they modify his food. They probably have things that they're worried about, but they're still more worried about taking away the mealtime pleasure that they receive and that he receives from being at the table. So what more can science tell us? Well, we also know that in the UK, 22% of deaths are related to solids and liquids in the lung or airway, and that 29% of hospital expenditures is for children with neurodisability when they are in the hospital system, and many of those are there because they have respiratory conditions. We also know that there is a difference in life expectancy with those with the greatest movement limitations, those with seizures and intellectual disability, and eating difficulties may actually contribute to that shorter lifespan. We also know, in contrast, and this is a little aside, while the life expectancy is shortened for people with the most significant disabilities, in the GT era, we actually wonder if there has been increased survivorship, though we don't know if that's related to nutrition or because the GTs actually impact the aspiration risk. We don't know that. The GT era is usually considered the past 30 years because in Manitoba, as an interesting little fact, the first GT was placed in 1985. So while there may be cause of death related to aspiration, may be increased hospitalization, and may be decreased life expectancy for children who have eating and drinking difficulties, we still don't understand exactly what all of these points equate to when we're looking at individual cases. So one would think that if we know from science that there are increased risks, if we investigate and manage the aspiration, then the logic model would tell us, well, we should decrease hospitalization, we should improve health and well-being, and perhaps even the life expectancy for children with eating and drinking difficulties, right? Well, it's complicated. Well, numerous authors have shown us that there is an association between respiratory illness and aspiration. Others have demonstrated no adverse health consequences from documented aspiration at all. So that places us in a quandary. So the school is saying we can't have him aspirate because he's at risk, but we don't always have the science to back us up. In fact, in this most recent study, this Tanaka study here, they demonstrated that if children aspirated, it wasn't the food that was the problem, it was only their saliva that was the problem. So that places us again in difficulty because we can't say dogmatically, the school is right, you can't feed this child. So does the science support the school, or does it support the parent's wish? And you might say, well, it actually supports both. Let's look at another contrasting case to help move us beyond aspirational thinking. And I'm going to tell you about this little one who I call Navak. And again, the pictures are from the internet. And this gorgeous little girl taught me a lot about aspiration about 25 years ago. I saw her as a 3-year-old. She had mild, what we would think of as fairly mild motor impairment in our setting, where we're so used to children having significant motor impairment. She was able to walk with assistance. She had a mild neurocognitive disability, but nobody knew whether that was related to the fact that she had spent an awful lot of time in hospital in her 3 years. She lives in a stressed environment. There's crowding, there's poor air quality. And she's been in hospital and medevac to Children's Hospital in Winnipeg many times from her far northern community. She's had multiple pneumonias. She now has chronic lung disease already at 3 years of age, and she wasn't born preterm, so she had no pre-existing risks for having chronic lung disease other than the recurrent chest infections that have plagued her since she was an infant. She coughs when she's eating and drinking. She drinks with her bottle lying down, and she has a ton of dental caries. 25 years ago, the first thing we did was look for aspiration in this little girl because we were seeing many little people like her. We assessed for swallow dysfunction, we assessed for reflux, and we looked at why is this little girl got chronic lung disease? And when we saw the swallowing study, a picture of which you see here, so the bottle is in her mouth, there's contrast going down into the pharynx here. And here it's splitting apart and you're seeing food. This is milk, thin milk going into the airway, and some contrast already in the airway, which is this, you can appreciate a bit of a paler tube here, sitting here. And you can see the pooled contrast here, some of which is spilling over. And we opted to put her in the supine position, which we don't normally do during a swallowing study. We don't usually want children lying down when we do the swallowing study, but because she was drinking the most of her bottles lying down, we wanted to see what is the effect of putting her in the supine position when we're feeding. And look, here is the contrast in the esophagus. And look at here, this is contrast heading up into her lung. So this stream of contrast is filling up her right upper lobe when she's lying down. When she's sitting up, it probably isn't entering quite as rapidly, but when she's lying down, she's getting food all the way up there. So we said, okay, well, we know why she's getting sick. We acted assuming that aspiration was the whole problem. We stopped the oral feeding, we fixed her teeth, we did aggressive respiratory rehabilitation. And because much of that had to be done in Winnipeg, her parents and Nivak experienced better air quality during the time they were in the city because they weren't living in such crowded circumstances as they had to in their home community. So we thought we had made her better because we improved the aspiration. But she got better very quickly. Her swallowing safety improved every time we checked her. So within a month, a swallowing study showed that she was able to handle purees, whereas previously all textures were aspirated. Her lung health improved. She had no more hospitalizations. And that gastrostomy tube that we had put in, well, it was removed within a year. So it really got us thinking, is aspiration the culprit here? How could she have gotten better if aspiration was the sentinel problem that caused all of this? And which factor contributed most to her improvement? And in feeding clinic, we contemplated this over and over. Barb Borden and I racked our brains. Barb wrote a master's thesis on this question. And we started asking ourselves, why don't all kids get sick when they have aspiration? Would time have been the best healer for her? Was it aspiration at all? And what could we have done better? Because we sure didn't pay attention to a lot of the F words because of the disruption that we caused to her and her family. Well, it taught us that aspiration is complex and determining the significance is often challenging. We know that not everyone gets sick, and here are those articles again, and there are more. And there are new articles coming out that's saying that if you put in a gastrostomy tube, you actually don't have fewer hospitalizations. There are fewer hospitalizations if you modify the child's food texture than if you put in a gastrostomy tube and bypass the aspiration. Respiratory illnesses are the same in children who are orally fed or who are gastrostomy fed. So do we make a difference by trying to address the aspiration alone? There's also an interesting study done in adults who long have been known to have increased mortality when they have a gastrostomy tube. That a careful hand feeding is just as safe as tube feeding for them. And maybe that's related to those multiple intangibles that come when we're eating. So the seminal question is, are aspiration and respiratory illness causally related? Does one cause the other? Or are they simply associated? If they're associated, what comes first? The chronic lung disease or the aspiration? These are things that put all of our teaching right on their head. So does aspiration cause pneumonia? Well, again, there was a very important paper in the late 1990s that looked at a lot of different people who had an aspiration pneumonia. So they wanted to follow them over time and look at what are the factors that contribute to these people, and they were adults, excuse me, having an aspiration pneumonia. And you'll be surprised to learn that when they were unable to self-feed, that was the greatest risk of developing an aspiration pneumonia. So you can't feed yourself, you can't pace yourself, and what happens? Well, somebody makes a mistake in the way they're feeding you and doesn't allow you to clear, and you make a mistake. So the act of self-feeding is an important part of our swallowing safety. So the second most important factor was smoking. Those individuals in the study, and again, it was an adult study, who were smoking were at much greater risk of an aspiration pneumonia. The third most significant factor, dental caries. You got a mouth full of bacteria. We all aspirate at night. When you're lying down and you aspirate your spit, then you're at more risk of developing an aspiration pneumonia. And lastly, multiple illness. So if you're sick a lot, you're more likely to have an aspiration pneumonia. Well, if you look at this list, all these people had swallowing studies. All of these people had reflux assessment, but none of those factors entered the top 4 causes of aspiration pneumonia. Aspiration's not listed here, right? Factors perhaps associated with aspiration are listed here, but aspiration itself did not enter the top 10 factors that are associated with aspiration pneumonia. Well, again, that changes the way we think about aspiration, doesn't it? So let's look at these 2 little people that we presented already. Well, one is no longer drinking from a bottle. You say, well, what's that got to do with it? Well, if you drink from your bottle lying down half asleep, is that the same as not being actively engaged in the feeding process, the self-feeding that makes feeding safe? So can we make that better? Can we look at that one factor that in adults we know contributes to an aspiration pneumonia? The second factor that was important was that the adults were smoking. Well, one of these little people has better air quality exposure than the other. Can we improve this? And will that make an improvement in health and well-being for them? Nothing to do with changing the aspiration. One has no dental caries, the other one does. Can we build a mouth care program into the nutrition care plan at school and actually do some good? Because the third most important factor was dental caries. We haven't addressed aspiration yet in either of these little people, but we have 3 ways that we may be able to improve their swallowing safety. One of these children was never hospitalized, so they're probably both aspiration, and the other spent long periods of time in the hospital. So is that why she keeps getting sick? And is that why she's aspirating? Just because she's had multiple illness, which certainly was a factor in the adults that were studied in this, in the paper that I cited. So clearly the characterization of aspiration is not always straightforward. And to quote Kelly Weir from Australia, she says that aspiration is an important risk factor for pneumonia, but in and of itself may not be significant enough to result in negative consequences. And that really changes the way we need to approach aspiration and helps us focus beyond aspiration. It's important, but not in and of itself. So for aspiration to matter, I think you need a perfect storm. And what does that perfect storm look like? Well, Maybe if you aspirate, you don't get sick until you have a viral illness, or someone new feeds you, someone new who doesn't know your feeding style, who doesn't know how to pace you. Or you start in a daycare and the air quality is compromised because there's a smoker who lives there. Or your mouth is full of cavities and all of a sudden you have a higher bacterial load, and that aspiration, that irritation and inflammation that it causes may get you into trouble. Well, as I said before, this puts our thinking on its head and really requires us to have a paradigm shift. We need to think of aspiration in terms of its significance, but not simply a limiting factor. Our discussion today is not for me to minimize respiratory illness and say it's not a big deal and it doesn't matter. We know that respiratory illness is more common in children with neurodevelopmental impairment. Actually, respiratory illness is the most common factor to cause morbidity and mortality in people with disabilities of any age group. It certainly is a limiting factor in many ways, but we need to, as therapists, as people involved with kids with disabilities who want to be at the table, we need to explore that risk of the balance. We need to explore the balance of risk and participation and ensure we're not shutting doors that don't need to be shut. So simple things are, if the child has trouble with bolus control, we can make the bolus more cohesive, put some mayonnaise in with the rice. I know that's a little gross. They may have a poor swallow trigger. Well, let's improve the flavor. Let's sparkle up the water. Let's see if that will help trigger the swallow and make it cleaner. On the other hand, if there's constant coughing and choking, maybe we need to eliminate it. Maybe we need to limit to tasting or pleasurable motor activities. But this is where our favorite words come in. And this is where we can use a framework developed that fosters participation. And you all know this. The health condition of any of the children that we've talked about is their mild neurodevelopment. They're, in one case, fairly, what we would say, mild CP with a GMFCS of 2, and the other one with a GMFCS of 5. And we have opportunities in fitness, in motor, in functioning, in friends, in family, in fun, to address what are all the factors that are related to aspiration. We can call the health condition aspiration too, and then look at, is there impact to the strength, control, endurance? Are we taking enough time to feed the child? Are we taking too much time to feed the child? Are we ensuring good positioning and alignment? Are we addressing the aspiration by looking at managing secretions? Are we addressing the respiratory concerns by ensuring that the child has airway clearance and is supported in doing that? On the other hand, when we're looking at functioning, can we address the functional motor ability? Well, maybe we can't, but maybe we can address the food so that the activity can flourish. And maybe there are adaptations that we can make so that the participation with family and friends and daily activities can continue. Environmental factors clearly play a role as well in what we need to address to make feeding safe for kids and welcoming them to the table. Positioning is a key. We need to make sure that things are safe across different environments, make sure that seating can happen, make sure that there's enough time to eat, appropriate utensils, all of those things. Not fixing the children so that they fit what we think should happen, but looking at the factors that we can actually modify. And the beauty of the favorite words is that it provides us with a map and an activity that we can participate in and that families can participate in with us to say, well, which of these factors is impacting the eating activity? Which of these can we modify and look at making better instead of just closing the door when we see that there's aspiration? So that systematic addressing of modifiable factors is not always easy to do, and it really is what makes our world interesting. So we can mitigate risk and foster participation by addressing all of these things. And I'm a firm believer that good nutrition is the cornerstone of pediatric care. So we for sure want to address that nutrition and care. We know that of the things that we can do for children who have neurodevelopmental impairment, ensuring that they have good nutrition is one of the cornerstones of our activities. And for really small children whose brains continue to grow and need lots of calories and energy, we know that nutrition is the most important tool in our rehab toolkit. So that is something we can address. And one of the few things that's evidence-based, because we know that children who are well nourished tend to visit hospitals less, and they are not missing school as much, and they appear to have much less contact with the healthcare system. So that's something we can do that mitigates risk because it improves the children's health and well-being. And even if there's some background of aspiration, it gives us something tangible to work on and look at how we can achieve that. And sometimes that's not by oral means, I grant you. We can foster that independent eating. And if we can't foster independent eating because the cost of independent eating may be efficiency, and then we may not be able to nourish as well. So those are intertwixt and intertwined. But we can make sure that at least those who are feeding are able to pace the children appropriately so that we don't add that to our risks. We need to match the texture, viscosity, nutritional requirements to their needs and skills, not the other way around. So just because other children are able to choose steak, it doesn't mean that either of the children we talked about will be able to do that, but that doesn't mean they can't eat. We need to match their skills to the foods that we offer. And those may be different at school, where we may have to blend a bit more in a distracted environment, let's say, where the children are not able to concentrate on the eating as much. We may need to match that differently than parents can at home in a relaxed environment and where they are more able to address some of the factors that may be tricky for those of us who don't know the children well. Position. We do need to make sure the children are positioned comfortably. We need to improve their dental health. Still the most common cause for admission at Children's Hospital in Manitoba, and a very significant determinant of health in our province. Address air quality. Easy to say, difficult to do, but I think that we've seen a change in people's thinking about air quality in the homes in the few decades that I have been working. And that 30 years ago, people were smoking inside, and it wasn't unusual for children to be exposed to smoking. We know that increases their risk. We can perhaps address that and foster that and encourage families to continue to smoke outside. I know that doesn't make it perfectly safe, but if children repeatedly are inhaling smoke, they repeatedly are inhaling particulate matter. If they're inhaling particulate matter, their airway says, I guess this is what we do. And the airway is no longer as responsive to foreign material in there. And the coughing is not as consistent with stuff in your airway. treating the secondary health conditions. We know from that adult study that making kids healthier, being aggressive with their secondary health conditions that are making them sick, and perhaps increase their aspiration risk when they're sick, is a significant risk factor. And this has become something that, whoops, that's a very squiggly line, but something that I've become more and more interested in, primarily from looking at papers coming out of the developing economies, where they've looked at what training does to families in crisis, looking after children with neurodevelopmental impairment. Yes, we can address the body structure and function, and we as professionals have a strong role in that. We can address the environmental factors, but training comes up in multiple of our boxes here. And training is something that the people who are feeding the children want others to be aware of, but it also decreases risks for children, and it changes how children are treated. And if we can, as professionals, say to school settings, for example, let's look at improving the feeding safety by positioning, by training you how to approach the feeding, maybe we can make a significant impact. Why we need to train kids? Well, the kids are totally dependent. Their skills are needed across different environments, and often there's a lack of knowledge of service provider. Imagine being that educational assistant thrown into feeding one of our complex kids in a school setting without any supports and without knowing how to do it. Well, yeah, you're not going to support the chin because you don't know that that's important. You might not help with lip closure, and the food may all spill out. And you may give the child a food that's inappropriately textured. So the training has taken on a new meaning and a new feeling amongst people who are working with kids with disabilities. Need to get rid of that mismatch of between the child's skill and the skill set of the feeders. And parents want us to be better at it. And maybe that's what they want us to teach the people who are around their children. Again, so that we don't limit, but we foster participation. And some of the key components of looking at feeding training are looking at those oral motor skills, looking at positioning. How are you going to eat if you're positioned like this? How are you going to eat if your mouth is open and you can't get a seal? How would someone know to give that manual support, or which utensils worked, or simple things like using a cutaway cup? How do we know about food safety, or about presenting food, or about airway clearance? How do we know about ending meal or troubleshooting unless someone has taught us? And remember that eating and feeding are really important communication and socialization skills that most people want their kids to participate in. So training decreases fear, focuses on participation and socialization, and that pleasurable sensory activity. So it impacts everyone involved in the eating process. And I have this, coming to the table here is a website from the HMS School for Children with Cerebral Palsy in Philadelphia. And I took my friend Marianne Gellert-Jones is a speech and language pathologist there, and she kindly provided me with a slide that I adapted for this talk, looking at the favorite words and how they impact feeding. But there are videos, training videos here at the hmsschool.org /coming to the table, and resources that can be used. I have that on one more slide, so you'll see it again if you didn't get a chance to write it down. So to move beyond aspirational thinking, we need to mitigate risk in any way possible. We need to recognize the importance of eating to family and to children. And we can use our favorite words to help map out how we might make it better for children. So you're probably dying to know what happened to Adam. Well, the school, the parents, and health professionals entered into a shared decision-making process. And the shared decision-making process is one of the few things that we actually know works. So we may not be able to say that gastrostomy feeding improves a child's aspiration risk, but we do know that shared decision-making processes improve the life and well-being of children and their families when they're engaged in properly. There are over 100 papers, randomized controlled trials, looking at shared decision-making as an appropriate process for many of the things that we do as health professionals in the care of children with disabilities. So what does that involve? Well, this is very simple. There could be an entire talk on shared decision-making. And you might ask, is it an art or is it a science? And I think it's a bit of both. But in shared decision-making, we engage and gather information together. And we look at what happens at the school and what happens at home, and why is this there, and what are your cultural values, and how is eating important, and what does Adam like about eating at school. We can deliberate and assess the risks and address modifiable factors together. So maybe the school is really worried about lumps in the puree. At home, the mom just mashes the foods. Well, maybe at school we can blend the food, and maybe that solves some of the problems. Or maybe we can do something even more interesting and look at has Adam been sitting up too long before the mealtime? Is he tired when he's going into meals? Does he need an alternate activity to decrease the spasticity and improve his motor function so that he can sit better and tolerate that half hour at the table? I know at a conference I was at with Diane Sellers, who is the author of the EDACS, the Eating and Drinking Ability Scale, that we can spend another hour on. But she presented a case of a boy who had very significant dystonia. And his parents had refused gastrostomy feeding on several occasions, but he was known to aspirate on a video swallow. But he went into the eating process at school when he was in pain. He had been sitting up all morning in class and he was in pain, and he was quite dystonic and he was tense, and he positioned his head in an unusual position, so swallowing was more difficult. So some very clever therapists at school realized that if they put him on his bike, they let him rest at about 10:30, then they put him on his bike. And as he had the motion on the bike, he relaxed. And then they were able to transfer him in his chair, and he did so in a much more relaxed position. And when positioned appropriately, he was able to get through a 20-minute meal. It was a shortened meal and a modified meal, but allowed him to continue eating at school. And then when he had a rest on the school bus on the way home, his mom was able to feed him again when he got home. So while he was known to have aspiration, this deliberation about how we could make this process safer improved his health and well-being at school, and he was able to manage without a gastrostomy. And unlike the cases that I've presented that have been modified from what I've seen in the past, this the story I've just told you is an actual one, and I understand the young man lived from age 14 to age 24 with this modified feeding plan that had been derived with the shared decision making. So is it art or is it science? Well, I think if it's well done, it's both. Deciding together, feeding's a team sport. We know that. We can support each other in it, and we can help train the people who are participating in it by not closing doors, but opening doors and training them appropriately. So we can negotiate with the school, we can train the trainers, we can ensure that there's positioning, augmentative lip closure, addressing the consistency and viscosity of food, talk about smoke exposure to the family or air quality and what's going on with that. And can we improve that? Because that may help improve the lung health. And we can ensure that good mouth care is part of the nutrition plan. And we did have cases like Adams and Feeding Clinic where there was a lot of opposition from the school to engage in feeding. And I really have to say that the process of talking to school and negotiating and working it through together for a number of children, it improved their feeding plans, and they continue to orally feed through their childhood years and not necessarily developed aspiration pneumonia. In fact, most of them surprised us that they really didn't get sick until they got another illness or they had a significant change in their motor function. And it's been amazing to me over the 2 years of the COVID pandemic that we've actually seen very few children with complex medical needs in the hospital, where they were always, there was always someone there with complex medical needs and always someone who had the diagnosis of aspiration pneumonia on their charts. And that diagnosis just about disappeared until the third wave or the fourth wave with Omicron. Children were relatively healthy, and we wondered, where is aspiration pneumonia gone? Well, maybe it's gone when the children are generally healthy as well. So the lessons that I've learned over the many years of watching children eat are that certainly the concept of aspiration is really complex and can never be our only consideration for mealtime management, because that really is multifactorial. I've learned that decisions regarding eating and drinking challenges need to be flexible. We need to understand that children get better over time, and it's not necessarily what we've done or what we've fixed, that the aspiration itself may not be the most significant factor. We also need to be very sensitive to cultural, economic, and family realities, and those need to be talked about, and they're very real and need to be incorporated in those mealtime management plans that we are often asked to participate in. I also learned that incorporating that shared decision-making is probably the most important thing that I've learned in 30 odd years of practice, close to 40 years of practice. And that I've learned that the favorite words construct really helps to rationalize the supportive care model that we like to have, that we have an integrated family approach to our care. So we need to consider the art and the science, because that helps get kids to the table. And that's the message that I want to leave you with. Don't let aspirational thinking close doors, but let's look at all of the factors in the art and the science of feeding and looking after children with multiple needs, and see where we can open doors when we think creatively. And I'll leave you with the coming to the table video, and welcome questions for the few minutes that we have left. Thanks very much for your attention.